Thank you, ma'am. So, workup of a case of microbial keratitis. I think this would just cover the bare basics, and the subsequent speakers will also be touching upon these factors pertinent to the microbial organisms they will be dealing with. So I'll take you through this talk on these lines: definition, stages, classification, workup, clinico-microbiological correlation, and then certain factors pertaining to the management. The corneal ulcer, by definition, is a discontinuation in the normal epithelial surface of the cornea associated with necrosis of the surrounding corneal tissue. It goes through the stages of progressive infiltration, stage of active ulceration, regression, and cicatrization. The causative organisms can be many, the common ones being bacterial, fungal, protozoal, and the viral as well. So if you want to classify it, again goes depending upon the morphological involvement, which could be of the stroma, which could be superficial or deep. In deep, you would have the interstitial, the stromal, and the endothelial keratitis. And you could also classify it depending whether it is being suppurative or non-suppurative. The clinical features or the classification of a keratitis based on the severity of the ulcer could be either as mild, moderate, and severe, or a grade 1, 2, or 3, depending upon the size of the ulcer, the depth of the stromal involvement, the location of the ulcer, the anterior segment reactions, and the scleral involvement. As vividly described in this table, it could be less than 2 millimeters, a 2 to 6 millimeter, or a 6 millimeter ulcer. The involvement could be superficial. If only 1/3 of the stroma is involved, it could be 1/3 to 2/3 of the stromal involvement, and when it's extending into the deeper stroma, it becomes a severe or a deep keratitis. Again, depending on locations and the presence or absence of anterior chamber reactions, your classifications could go on to mild, moderate, or as severe. Keratitis. In today's cases scenarios, workups of microbial keratitis will also pertain to certain aspects when you want to consider other treatment options such as intrastromal injections or intracameral injections. When you want to manage an ulcer using a cyanoacrylate blue or bandage contact lens, you're going to look at the morphological factors which will be where this treatment will give success in managing your keratitis. You would also want to examine in terms of whether you want to give them conjunctival flaps or take them on for a therapeutic keratoplasty or for tectonic or therapeutic dull surgeries. Evaluating risk factors, evaluating the use of other concurrent ocular medications which have probably resulted in the microbial keratitis, and compliance to the treatment which is going to be offered will also be an important factor. When you look at predisposing factors, it could be ocular, systemic, or occupational. The common ocular factors involved being trauma, contact lens wear, lid infections, lid and adnexal infections. The ocular surface disorders form a very important part as a predisposing factor to occurrence of microbial keratitis. Allergic eye disorders can also lead to microbial keratitis. Bullous keratopathies, concurrent topical medications, and prior ocular surgeries also remain important ocular causes of infectious keratitis. Systemic diseases, of course, diabetes mellitus. Stevens-Johnson syndromes can also, the persistent epithelial defects in these cases and the poor hygiene and the severe ocular discomfort predispose to ocular infections in these cases. Immune deficient patients, as in HIV infections, advanced malignancies, alcoholics, extremes of age, and occupational hazards like farmers, animal handlers, gardeners also are prone to infectious keratitis. When you examine, you're going to look for the presence or absence of vesicles, which can point to whether it's an infectious ulcer or it's because of a viral cause. Look for other lid abnormalities as would be in cases of neuroparalytic or neurotrophic keratitis, and of course exposure keratopathies. A careful examination of the ocular adnexia is imperative. Of course, goes without saying, a visual acuity assessment and a slit lamp biomicroscopy. It is important not to stain the ulcer with fluorescein before you've done a thorough examination and before you've completed scraping of the ulcer. When you're looking at lids, look for lid edema, blepharospasm, the conjunctiva, look for chemosis. Corneal ulceration per se would be we're looking at the epithelial defect, the infiltrations, the margins, ulcer floor, the area of necrosis and stromal edema, hypopyon iritis, KPs and pupils in the anterior chamber, and of course the intraocular pressure and posterior segment as well have to be evaluated. A proper corneal documentation, in case you do not have photographic documentation of the ulcer, goes a long way in helping you in effective management of the ulcer subsequently. I think this was vividly covered by our earlier speaker in the earlier session, where you would look at the actual area of infiltrations, you look at the area of epithelial defect, you look at the surrounding area of the cornea which is involved, and the deep endothelial plaques as well. And this diagrammatic depiction or a photographic depiction helps you to assess how well the ulcer is responding to the management in the subsequent follow-up of the case as well. Here you're seeing a hypopyon corneal ulcer of mycotic etiology, which has been documented well. A quick look at the various features again before that, I think we look at when you're doing scraping of these ulcers for preparing smears. The good thing is take a sterile or a clean slide and mark the undersurface of the slide so that you know where exactly the material is to be deposited on, and then you deposit it on the front surface of deposit the scraped material on the front surface within the marked region, so you know where after staining you have to look for. Scraping again could be therapeutic or diagnostic as well, and diagnostic for a smear and for obtaining culture, so that you have an etiological diagnosis which helps you in effective management of your case. This is an infectious keratitis in a post-LASIK case, where we are lifting up the flap to obtain sample for scraping. As you can see, the infectious keratitis is in the deeper bed, and this is not going to be amenable without being able to lift the flap as well. And when you make smears, you would make smears for the gram staining for potassium hydroxide to look for fungal hyphae, and special stains if you're suspecting special parasitic keratitis, such as in cases of acanthamoeba. And the cultures will go in blood agar, in chocolate agar, and sabrodextrose agars for the various organisms which need to be identified. And if there are specific keratitis suspected, such as microsporidia or acanthamoeba, you need to take extra smears and slides in order to be able to make an effective and early diagnosis of these cases. This is a quick look or overview of all the various microorganisms which could be affecting. You have diplococci, gram-positive cocci, gram-negative bacilli, fungal hyphae, and nocardia hyphae, which could be confused with fungal hyphae and acanthamoebal cysts, and the various culture medias as well. I think I'll just quickly run over this and come into certain factors or advances in management of infectious keratitis or diagnostic tools which help us is the in vivo confocal microscopy. In cases where your routine diagnostic methodologies are not helping in diagnosis, you would probably want to use corneal biopsies and also PCR detection methods. And when we are looking at real-time PCR methods in this, I think these results are not as quick as you would get your smear examination, but their sensitivity and specificity do match your smear examinations in the various microbial organisms. Due to lack of time, I would not go on into the depths of these, but if you're looking at confocal microscopy or how confocal microscopy is going to help you in the diagnosis of infectious keratitis, this would be in cases of deep keratitis, especially those following refractive surgeries like LASIKs or radial keratotomies and or incisional keratotomies, and it will help you to pinpoint, and you do need to do them in early cases of keratitis where you're able to properly image, and it is not really useful when it goes on to advanced cases and when your stroma has gone into has become hazy or more opaque. And Corneal biopsies, when your ulcer, you're not able to isolate any organisms on your routine microbial investigations, is when you would like to do corneal biopsies, and these can be done as routine, as simple procedures in your theater, and you do take out, separate your necrotic material and send in a tissue at the margin of the ulcer, and this would help you in providing an effective diagnosis as well. Looking at clinico-microbiological coriations, the various fungal looks, the various morphological presentations of fungal ulcers. Acanthamoeba keratitis in India is to be remembered, it's not commonly associated with just contact lens wear, but it's still trauma which is the leading cause, and the presentations can be varied. Ring ulcers with stromal necrosis here, and the staphylococcal ulcers, again depending whether it's an immune pathology or it is a frank infectious pathology or adnexial infections. And goes without say that we do see, or we probably do miss out, a lot of microsporidia and nocardia and do confuse them with fungal keratitis as well. Chemical injury and Stevens-Johnson's form two important aspects in our day-to-day cornea practice, which also remain important predisposing factors for infectious keratitis. And recurrent ulcerations and dystrophies also can predispose to infections. Scenarios of post-keratoplasty infections also need to be looked at carefully, and again differentiate between necrotizing viral or viral infections occurring because of, in the extremes of age, and other immune compromised scenarios. So again, I think with this I've almost covered most of the workup of corneal ulcers, and it will be taken up in greater detail with my speakers to follow. Thank you.
Thank you, Vanathi, for a wonderful talk.